Uh, Thank you for allowing me this time to be the last session. And we're going to talk about new indications on the horizon. And my background is in neuromodulation since the 90s, began my career with Advanced Bionics, where I wrote the original business plan. I'm very excited about the panel because at different stages, all of the panel members have also been at Advanced Bionics. So we have today Tony Arnold. Tony, I presume, Tony, you can hear me.
Absolutely.
Maybe you can give Jim a thumbs up. But Tony has had a long career in medical devices. Most relevant for today, he was the former CEO for 8 years for SetPoint, which is a household name, and certainly in this room here. He is also the current president CEO of Sensida Corporation, and he also has his own consulting firm to help early stage and companies in medtech. Also, we have Eric here. Eric, who also was at Advanced Bionics. He's from Case Western, where he has a PhD in chemical engineering. And most recently, he's the program director in the Division of Translational Research at the NINDS. He is also involved with the HEAL initiative, which is an important organization within the NIH for this group. And he'll speak a little bit about some of the new opportunities in those particular areas. So just because we started the day with Jim's talk and just wanted to kind of circle back in terms of a little bit, just as an overview in terms of neuromodulation bioelectronic medicine. I'm just going to show this, just as a refresher, as well as the various targets, whether it's the vagus nerve, hypoglossal, sacral, and tibial, or a saphenous nerve. In preparation for this, and kind of as leading setting the stage for our discussion, and I've been wanting to do this for quite some time. We're not 100% finished, but I wanted to look at all the clinical trials around electrical stimulation that was relevant for this talk. And so I went to clinicaltrials.gov, looked up bioelectronic neuromodulation. These are the key terms: neurostimulation, et cetera. It yielded about close to 5,000 clinical trials. I got rid of the unique ones and isolated those that were relevant. And these were all the indications that, or the top indications that were there. And some of these we've talked about today. What was interesting about this group, if you then did a word count under the conditions, the top ones look like this. So there's been more clinical studies around bladder than just about anything. But if you look at the term depression plus depressive disorders, it actually surpasses bladder. But there's, for instance, we've talked about dysphagia, and there's at least 13 studies that came from there. But you can see all the different indications that have been studied. And this is certainly, I didn't look at, we'll break it down by year. Well, let's look at just the last 3 years to see really where is the future headed from a commercialization perspective. But, we've talked about some of these, dry eye. I was surprised to see that there were 17 studies there. And, some people in this, they know the story of Oculive and Allergan, and but other ones, insomnia, alcohol addiction, constipation, et cetera, et cetera. So wanted to really just show this as a way to have a discussion around new indications, where are we headed from a commercial perspective over the next few years. We know that non-invasive, you can get to market, you're looking at Tivic Health as quickly as 3 years. The average for an implantable device, I would say closer to 10 years. If you look at more recent examples, Exonics or Inspire from inception through FDA, both about 7.5 years. And in one case, I think it was about $350 million they raised, and in the other about $650 million. Very different investment criteria for implantables than non-invasive. So that's why one reason I'm very excited about all the work that's going into non-invasive neuromodulation these days. So with that as a background, perhaps we'll start with Eric, just in terms of opportunities for early stage companies to take advantage of what is available within your programs, particularly around new indications. Perhaps you can lay out a little bit about your programs and how do we even as entrepreneurs work with you.
Sounds good. Can I share those slides?
Sure, let me get out of here. And you should be able to share. There you go. There you go.
Okay, well, thanks again for having me on the panel today. My name is Eric Kudak, for those I haven't met before. Today, I basically wanted to give a brief overview of the programs we have at NIH to support device development and translation. I work on a number of programs through NIH to support these efforts. Our NINDS Translational Neural Devices program, the SPARK program, the HEAL initiative, which stands for Helping to End Addiction Long-Term, which has a very strong component focused on pain treatments, the BRAIN initiative, as well as the NIH Blueprint for Neuroscience Research. For our NINDS program, and you're going to see a diagram like this on several of the slides I show, no need to take note of all these programs right now. I have resources I can share with you afterwards for anyone who's interested. But basically what we're trying to do is support device development and translation from early stages of concept generation all early stage clinical trials. And in our NINDS programs, you'll see several RFAs titled UG through UH3 opportunities. These are opportunities device optimization stage of development, and it provides grant funding for our applicants to take the device up to the stage of getting an IDE for their device or an IRB approval for a non-significant risk device. Those awards then transition to an early feasibility study clinical trial or a first-in-human trial, and we support those projects as they go through as well. For small businesses in particular, all NIH programs have to sort of entail a small business component to them. There is a congressionally mandated set aside of a percentage of funding for all of our programs that have to be spent on small businesses. So those projects do start at the very early concept generation stage, and they also go through the stage of early stage clinical trials. So those are a sort of a set aside pot of funding for small businesses that is there for you to come apply and get funded for your research and development needs. Similar to that is a new program called the Blueprint MedTech program. This is a program we have just recently launched in the past year. It's meant to be an NIH incubator for neurotechnologies to, similarly to the NINDS program, to accelerate the development and translation of new therapies for neurological indications. This program, how it differs from the NINDS program is that it involves all NIH Blueprint institutes, which basically means it opens it up to other indications that aren't only covered under the NINDS umbrella. The other big difference in this program is that NIH will be providing free resources that applicants can take advantage of in their projects, and they do not have to budget for in their applications and their programs. So the examples of these are shown at the bottom of the slide right here. So basically, when you apply for funding through this program, you basically say, I'd like to take advantage of the business development contract and the biocompatibility and animal studies contract. Then after you get the award, we work with our contractors to set up those services for you. So if you don't have those services in-house, or if you don't have access to a CRO easily that can help you with that portion of your device development, we are trying to set up a system where you can come to us and get that help as you need it. The next set of funding opportunities is through the BRAIN initiative. This is an NIH program that focuses on uncovering the underworkings of the brain and how it functions, and associated with that is several programs to support technology development and device translation to treat disorders related to the central nervous system. So these programs also have the later stage pre-IDE and first-in-human clinical studies components, but they also have several programs for earlier stage device development. So this sort of new concept generation R21 program is for high risk, high reward projects. Then there's traditional R01s as well as device optimization. I should say that although all of these are specific to small businesses, all of these are open to small businesses, and all of these are also open to foreign institutions to come in and apply for these as well. I'm shifting gears a little bit. I think most of you are probably familiar with the NIH SPARK program. This is a program that was launched several years ago. It stands for Stimulate Peripheral Activity to Relieve Conditions. So it very closely aligns with this bioelectronic medicine definition we're working with today. SPARK has just transitioned into phase 2 of SPARK, and for the final 3 years of the program, we launched 3 new programs, one focusing on the human vagus nerve. With that program, we're soliciting proposals to be able to come up with high fidelity maps of the human vagus nerve and how it interacts with organs. There's another program focused on setting up studies of people who already have VNS devices and doing some additional work there. I'm the co-lead on the SPARK-O or HORNET program, which is the Human Open Research Neural Engineering Technologies program. That one is aiming to develop open source neuromodulation devices so that researchers can have easier access to devices that they can use in human subject research. The last one is the Neuromod Prize competition. This is one that is ongoing right now and is going to be soliciting applications from people working in this space where they will to sort of demonstrate an outcome of neuromodulation with no side effects to it. That is the summary for today of the programs we currently have running at NIH to support device development, but I'm certainly willing to answer questions or talk later about these and how they work.
Great, thank you, Eric. I'll get back to you with a similar question, Eric, and the question, but I want to hear from Tony first, is in terms of what you're seeing in terms of applications, in terms of just areas, new areas people are pursuing. But Tony, you were involved with SetPoint for 8 years, I think starting at 2011 or so. And you were, SetPoint is a pioneer in bioelectronic medicine, and certainly, the first major initiative for any device for targeting inflammatory. Can you speak a little bit about that journey, taking on a new indication, and similar to Jennifer, where the question was, what would you have done differently? What have you learned about pursuing a new indication, and what advice can you give to others?
Yeah, probably a lot of advice.
Hang on, Tony. We got to get. Where's Jim? Okay, go ahead.
Great. So yeah, probably a lot of advice, both on the positive and the negative, Jeremy. I'm happy to share here and beyond if anybody wants to reach out to me. But SetPoint was an amazing journey with a just fantastic team and a group of great investors. So you've heard it all day, but it's very important that you know how you're going to get funded and that you have a solid group of investors behind you from the beginning that can ride out the storms with you. Because as you said, Jeremy, it's a long path. The path to commercialization may be 7 to 10 years, but that is not the path to full success. Even you and I spoke last night, Jeremy, being commercially successful presents its own host of challenges beyond just getting paid. But for us at SetPoint, a few takeaways we had was we did a few things different. I'm an engineer by training, and I tend to be that guy that I have a solution or a technology, and I want to go find ways to apply it to potential solutions. Well, at SetPoint, we did things a little differently. thanks to Kevin Tracy, we knew the cholinergic anti-inflammatory pathway. We knew of its existence. We knew generally what we needed to signal and where. So we were able to go out, Mike Falties and I, and somebody that's in the room there, Yakov Levine, were able to go out and really engineer a device and product to specifically meet the needs of our target, rather than having a Canon lead and saying, hey, where could we strap this to next? What peripheral nerve can we go to next? We had investors supportive to say, what's the right solution? What's the right product? So I'm really proud that we were able to develop a purpose-built product to do a specific task, to stimulate the immune system. One of the mistakes I think maybe that we made was, and I encourage new companies of this all the time, is we all elected to keep the device very simple, elegantly simple in the beginning. And in spite of that, as a mission that we had, let's make the device as simple as possible to prove that the therapy works. We still went more sophisticated than we needed to for a generation 1 device. And, that maybe added a couple of years to the early pathway. With that said, the device, that set point is, I'm confident will one day bring to the market, is really a spectacular device, but it costs time and money. And most investors, the first question they want to answer is, can you give me meaningful clinical evidence, ideally sham-controlled clinical evidence that shows that this works? If we have that and there's an unmet need, we can probably make a lot of money with that. So getting to that high quality clinical evidence as soon as you can, in my opinion, is the most important thing, both for the scientific community and the investor community. So don't lose focus of that. Make sure that that is the first and primary focus of the company coming out of the gate. There'll be time to innovate down the road.
Great. A follow-up question, Tony, where a lot of new indications start off at universities. Kevin Tracy had been working on the inflammatory response for some time, and SetPoint licensed the technology. What was that experience like, and how long did it take in your case in terms of the whole licensing process? And again, for people seeking new indications through universities, what guidance would you give them on licensing?
Yeah, the company I'm leading right now is licensed technology from UCLA Technology Transfer, and it depends tremendously on the institution you're working with. I'll say that with Syncytia, UCLA has been very easy to work with. They have been very streamlined and efficient. I didn't have that experience 12 or 14 years ago working with UCLA, but they have made it easy. The licensing deals have been very fair. They have people to really make it streamlined. So I think that's a great question, Jeremy, because that could be a deal breaker. If you get in with a university that is, or with somebody that holds the IP who is not conducive and doesn't understand what it's going to take to commercialize and just how much money and equity need to be shared to make this all work, you could have a showstopper. So I think it's extremely important to hammer out what those long-term, not just short-term, but all the way through commercialization, what those licensing agreements could look like. Talk to other people that have dealt with the institution you're looking at to see what their experiences have been. Like I said, I can tell you I'm working with UPMC now. I've been very pleased with UPMC. UCLA has become very amenable to it. But I've worked with other institutions that we literally, both at SetPoint and at Syncytia, we just said, so there's some good IP there. There's some good technology that we think has potential, but we're not willing to take on the transfer battle. It's just not worth the people you're dealing with either don't understand the complexity and aren't flexible enough, or they have unrealistic expectations about what their institution should get. So make sure you've done that work very early on. It only gets harder if you wait until you're well into the company to define what that license looks like.
Yeah, great. Thank you, Tony. Shifting gears back to Eric, and I'm just going to bring up the slide on the various indications for a sec. And I don't know what you can or can't talk about, Eric, but when you look at the applications being submitted into your various programs today, what are those various, what are you seeing? Are there any trends in terms of particular indications that you're seeing starting to emerge?
Yeah, it's a good question, and I don't want to pick out certain ones that are certainly not my favorites or whatnot, but there are a lot of more interest in gastrointestinal devices for sure. That is a growing area that I think has a lot of opportunity for people to be able to come into our programs to invest in, as well as pain devices. I know sometimes in this field, there's a carve out for pain devices versus other types of bioelectronic medicine devices. However, it's really, it's tied to the opioid epidemic and tied to what we're trying to do on the HEAL initiative. And there's so many different types of pain and pain indications and pain pathways that are really hard to target. And I think we need definitely more interest in those areas and more groups trying to go for those indications.
In terms of from a funding opportunity, are there certain indications, is it just the ones that you mentioned, that stand a better chance or than others in terms of the government's own focus or not? Does that play a role?
Most of the time it does not. The way we operate at NIH is to try to be a mostly investigator-driven institution where we're just, letting people come in with their scientific ideas and the indications and devices they want to study and sort of taking it from there. But there are sort of these special programs where NIH can have targeted efforts aimed at certain fields, like treating pain in the HEAL initiative or opioid use disorder on the other side of the HEAL initiative. So there are opportunities as they come up and as they're also mandated by Congress. So, those are sort of driven by public interest as well as, just the field in general.
Tony, I know you also do consulting to early stage companies and including neuromodulation. Did you want to comment on in terms of what you're seeing, if any, on kind of exciting new indications from some of the earlier stage companies you've come across?
Yeah, I tell you, I'm going to take it a little different direction, Jeremy, and there's a really bad audio feedback. So I caught most of your question, but I'll tell you something I think most of the people in the room will like hearing, and I'm excited about it. And that is, even as recent as 5 or 6 years ago, when I spoke to the big corporates, the people that acquire a lot of our technologies, they were really heavily focused on and even stuck in what you classed on your slide that you shared, slide 4, and traditional neuromodulation, where we're functionally blocking signals. We're not modulating organ systems or disease states. And they were very focused there, and they believed that their best money spent would be on things that incrementalized those technologies, where they took 5% more of the pain market, or maybe they even expanded the spinal cord stimulation market a little bit. And what I've noticed in the last 3 years in talking to the corporates, and it really is positive to me, is they are beginning to take bioelectronic medicine and the idea of functionally modulating organ systems in disease states very seriously. I've had a number of indication companies mentioned by them, anything from changing the way we do DBS from simply a blocking signal to using sensing and modifying brain function to improve memory, to dramatically improve Parkinson's outcomes. And of course, things like MS and Crohn's disease and RA. I'm hearing more and more talks about that from the strategics. And when I say talks, it seems to me that it's more than just talks. They seem to be willing to seriously consider funding those at earlier stages. And I think that's primarily because they see that there's probably more good that can be done even in those than just in functional blocking signaling. And there's a lot of money to be made in those markets. So you can help a lot of people tremendously, potentially with less side effects and pharmacologic intervention. And earlier we talked about how, I think one of the speakers talked about how these things probably will always be second or third line. I don't even accept that. I think they are now, and I accept that bioelectronic is second line now, but I don't think that's the way it'll be in 10 years. It can't come soon enough, but I believe that some of the stuff Eric spoke about and some of the things we're seeing now for, SetPoint's a good initial example, but there are plenty of others talked about today will change people's perceptions about how to get therapy, and bioelectronics will become more and more accepted. And the key to that is, of course, making it through the commercial challenges, but even more is how you commercialize those technologies, how you gain awareness, and how you bring the professional community on along with you.
Great, thank you, Tony. So since this is the last session, I want to make sure there's plenty of time. But we have a lot of pioneers in this room targeting a variety of new indications, which is very, very exciting. But I really want to open up to the room, whether it's to address to Eric or to Tony and myself or any of the others. I think that we should have a kind of a healthy dialogue for a few minutes. So, does anyone have any questions? Victor.
It's more of a comment, I guess, if it's okay. Since I worked at Galvani, I cannot say too much about that, but all of you can easily go on the patents website and see that Galvani owns patents for about 20 plus diseases, and all of them are in bioelectronic medicine. So this is just to show you the potential expansion where we can go. So all of you are welcome to browse the patents website, and there's a lot of exciting diseases there that at least Galvani has considered. So.
Great. And that brings up a whole other question from a new indication perspective. Or are you going to go up against a patent? How to get around it? Medtronic in particular, every company I've ever worked at, has thrown a patent lawsuit. Or not. It's very hard as a small company to lawsuit or not. But that's a whole separate discussion.
Hey, Jeremy,
build a fortress around it because that certainly gives value, and I'm sure some of the entrepreneurs
keep pointing to your microphone, Jeremy. It's very directional.
Excellent point. Other questions? Yes.
Also, the technologies we're talking about, but we don't talk about it. I'm just wondering if people are working in it or what they think of the aesthetic. It's just such a massive market.
Yeah, Howard Leonard, he has a whole portfolio, and one of them is in the aesthetics. I don't know if Howard's still online or wants to make a comment about that. And this whole idea of precision aesthetics as well is certainly a hot topic. I have one friend that's in that area. But Howard, did you want to comment at all? If you are talking, Howard, you're on mute.
Howard, are you there?
He may not be there.
Jeremy, can you stop the share?
So for those of us on Zoom, the audio is challenging.
Go ahead, Tony. Did you
An
want
example?
Go ahead, Victor.
I think Tony's talking.
No, related to this.
Where we lose the feedback.
Okay, maybe Tony's not talking. Okay, never mind.
Jim,
Okay.
can you guys hear me, Jim?
Here we go.
Okay, 1% of time. Tony, go ahead. You have the floor.
Yeah, the audio is very challenging, so I apologize. I think you said something about aesthetics in the last question, and I see Jeremy nodding his head. I have not been following the aesthetics field at all. You know, as you know, there's so many opportunities, but what I can say is, having heard Howard speak, looking at what's come across in this forum, I've had the good fortune to speak to, let's just say, most of the major strategics in the last month. I think that the field of bioelectronic medicine, you know, I would have told you 5 years ago we would be where we are now. It's come slower, and I think Victor can probably see this too. It's come slower than we'd like, but it is coming this way for investors. It will come this way from the professional community. They will begin to understand it better and better as more quality research is published, which means in the end, I think this field is only going to get better and better for funding. So I just want, for anybody there that's looking to innovate in this field, whether invasive or non-invasive, I don't know about aesthetics for neuromod specifically, but I'd say that if you have a group of patients who have a need and you can show some clinical evidence that's directional and show a platform that can take you there, you can get investors these days. And I think may have been Tony, but somebody earlier spoke and said, you know, clawing your way into that seed round may be the hardest part. Once you get a solid idea with a good group of patients and a few advising doctors behind you, if you can get through that seed phase and exit that seed phase with directional clinical data, you can probably have a very successful fundraising venture if you're tenacious about it and have a good plan. I'm more optimistic about this field than I've ever been. And I had, through SetPoint, I was able to raise, you know, more than 70 million for SetPoint, and they've gone on to raise far more than that. And I'm doing it again with another company. So just, I'd say if you're in the room looking at how you make this go, it's the best time we've ever been in. Maybe not for the IPO market, but for the venture funding and the opportunities to take a company forward, it's as good as it's been from funding. And I see too, Jeremy, I'll stop in just a second, but something I see happening that it's just becoming apparent to me, but though things are getting more expensive and we're seeing inflation, as I look around the suppliers in this field, there's more and more people able to make quality leads, quality cans, have answers about what's going to hold up and not. When we started in SetPoint with a very unique device, we didn't know what it would take to develop this device or how we would do our feed throughs. Nowadays, there's plenty of people that can help you. There's great vendor opportunities. There's great consultants out there that can shorten the time and number of mistakes you make. So it's a very bright time for this field.
Great. No, a wonderful note. Almost end on, but I want to give Eric any last words, comments about the session before we pass it over to Jim.
Sorry, I've lost internet again. But the one thing that came to mind when you were speaking earlier about sort of connections between, you know, having the right partners on board. One program at NIH that we tried to push and get more awareness for is the STTR programs of the Small Business Program, and that's really trying to connect academic investigators with more business savvy investigators, and by having those different types of expertise combined in those projects, it can really help facilitate more successful projects, I think, on both sides, because you have the stronger scientific component as well as the stronger business sense and path to commercialization. So.